Good afternoon. Guess what time it is? It is 4 o'clock straight up in the mountains, which means 6 o'clock on the East Coast and three in the West. And there is but one place that you need to be right now, and that is right here. It is Fertility with Fink and Friends. I am Fink, and you are friends, and it is great to see all my friends here as we do every Tuesday evening, live from Colorado Springs, where I am the clinical director of IVF services at CNY Fertility Colorado. And we have our folks joining us from all over the world here on our evening broadcast every Tuesday at this time, Fertility with Fink and Friends. We've got Facebook and YouTube and LinkedIn right here in the middle. We've got a couple of different Instagram feeds. We've got mine at Randy Fink MD, and we've got CNY Fertility's right here. How you guys doing? How's your week been? How was your weekend? You know, last week, the last few days of the week, we got a bunch of snow here in Colorado Springs, which is actually pretty unusual. People think, oh, Colorado, well, that's going to be you get snow all the time. We really don't get all that much snow here, but we got a big dumping that came in. It was something called the Albuquerque effect, I think, and it blew from the south and it sort of went up north, and we got probably over a foot, a couple of feet, and up in the mountains they got 2 or 3 feet of snow, which is really pretty impressive. But I hope your week is going great. We're seeing lots of friendly faces around here at CNY Fertility Colorado. As you probably know, we have a bunch of different locations in these great United States. There's 3 in New York, Syracuse, Buffalo, Albany. We have a monitoring center in Rochester. We have monitoring in Philadelphia. We have monitoring in Norfolk, Virginia. That will ultimately become a full service operation. We have a full service IVF and fertility center in Sarasota, a monitoring center in Atlanta, and here we are over here in Colorado. And gosh, let's see who we've got joining us here. Looks like Jenny Thiels, I see you here. And gosh, what did Jenny say before we go? It's right in front of my face. So I'm going to say you did my donor's egg retrieval on Saturday, and she got 35 eggs. Now we're preparing for an embryo transfer. Questions about an HCG wash versus boosters. What's the difference? And which one do you recommend, or both? And what about intralipids and PRP? Okay, so Jenny, what we're talking about there is the difference between the things that are on our part of our immune protocols. So an HCG wash is where we take some of the pregnancy hormone and place it inside the uterine cavity. A teaspoon or so of fluid goes inside, and what does that pregnancy hormone do? It revs up the receptors for pregnancy, so it may be able to improve implantation. HCG boosters are something that I recommend during a natural or a modified natural cycle, embryo transfer cycle. And what that is where you inject a little sub-Q injection of some of the HCG, the pregnancy hormone, which is metabolized in the body as progesterone. Progesterone is, of course, the most important hormone to the pregnancy. It maintains the pregnancy, hence the name progestational or progesterone. HCG booster becomes more progesterone. Now, if you're doing a medicated cycle, well, we're giving you that progesterone in oil. We're giving you a huge amount of progesterone, so really having to get more in the form of an HCG booster, not so helpful. An intralipid infusion is basically an IV infusion of some fat. And that is a very potent natural anti-inflammatory. It's kind of like getting an IV version of the keto diet. What it does is that it has a particular effect on a type of immune cell known as a natural killer cell. So it does some good things for you there. So that's kind of what that stuff is. I generally do recommend both HCG booster and HCG wash, that is boosters, if you're doing a natural or a modified natural cycle. You know what I'm looking at? It's kind of funny is I'm seeing I have like this blue haze right here on my Instagram, and that's from this really cool neon sign I have behind me here that says Fink and Friends, and it's backwards on the Instagram here because of the way the camera is, but it's not. You're probably thinking that it's my halo, but the halo is of course, gold and light and so forth. But the blue is just from the neon back there. So Jenny, I hope that's helpful. Now let's go back to the top and see who has joined us. H. Shu, as always, thanks for being here. And hello to Angelina Foxy, the finest cardiovascular nurse practitioner in the Midwest up in Minnesota there. Thank you for being here. Hello to Jess and Michelle Marks. I hope you're doing well today. We've got our fingers crossed here for you. Mariah Wagner, Emily Watson, a special hi to Brandis, our wonderful nurse practitioner here from CNY Fertility, Colorado. Thanks for being here, Brandis. Let's see what we got on the CNY Instagram side. Joining us first is number one is Rosa SD. Rosa, thank you for being here as always. Hello to Beth Patrick and Witchy Bliss. Talented Hands 84 LLC. Joan Photoliciously, good to see you. D Demic, do we do Photoliciously ask natural IVF? Yes, we do. What is natural IVF? Well, IVF, as you know, is where we will, generally speaking, rev up the ovaries in order to get you to produce as many eggs as we can get, which we then retrieve from the ovaries under a little sedation done in our office. Natural IVF is where we are not doing ovarian stimulation at all, or sometimes we might do some mild stimulation just with some oral medication. And then we do a retrieval, just like we would if there are multiple eggs, but in general, there will probably only be one. So do we do that? Yes, we do. It has the same cost as regular IVF with all the medications. The advantage to doing IVF with all the medications is that we are pretty assured that, we're going to do our best to try to get as many eggs as we can. Whereas with natural IVF, we're getting that one dominant follicle is what it's called that you typically make each month on your own. Do we do that? Yes, absolutely we do. Chef Blackney, hello, and hi to Jessica Funk Garvin. Let's see, Chili Nilly, Simply D, Ashley and Company. Jen Milani, hello to you. Bryn, hello. Brace face Tiara, hi, how are you? Kay Shamrock, Bryn asks, had an MC on 9/27, no period yet. Can I start another miscarriage? Okay, on 9/27, can I start another transfer if everything is at baseline? Well, there is some data, Brent. First of all, I'm so sorry to hear about your miscarriage there, but there is some data that shows us that that doing an embryo transfer or getting pregnant before you have had that first normal period may increase the risk of abnormal placenta implantation. So I generally recommend that you clean that lining out. So if you haven't had your period yet, I would say it's not unreasonable to go ahead and do a baseline. Let's see what's happening to your lining. Let's see what's happening with your ovaries and your hormones. We can always give you a clean out with a little bit of progesterone. Now, under normal circumstances, we don't have to do that. But after a miscarriage, there is some data that shows that we do better by having that first normal bleed and then proceeding after that. So that's my thoughts there. Ashley and Company, good afternoon. Just went for my 20-week anatomy scan. That is fabulous. You did my retrieval. Thanks so much for our sweet baby boy. Any news on our Thornton location? Yes, indeed. So Thornton is a city up kind of north of Denver, and CNY is opening a monitoring center in Thornton, and that should really probably be opening, kind of any time now. So congratulations, Ashley, on that 20-week mark. Some folks do their anatomy ultrasound at about 16 weeks, some at 18 weeks, some recommend doing it 20 weeks. But basically, that's the ultrasound in pregnancy, where they're really looking for all these individual bits of anatomy. They're looking at the hands, they're looking at the neck and the spine, they're looking at the four-chamber heart, they're looking at the extremities, at the limbs, and really at the kidneys and at the bladder and at the stomach bubble, and looking at all those things to make sure that anatomically the baby growing on the inside looks good. So congratulations there. People wonder, well, why can't I do that? At 10 weeks with my ultrasound? How can you know that everything is normal? And honestly, you can't. So when the embryo is early on in the first trimester, and we do that ultrasound, really what we're looking for is do we see the heartbeat? Because once we look and we see the heartbeat, we know that 95% of those pregnancies will continue on without having a problem. So that's kind of the best odds we can hope for at that point. But we need the baby to be a little bit more grown before we can look and determine anything about the anatomy. So that's typically done at about 20 weeks. And you say, well, why you do it at 18, 20 weeks? Why wouldn't you do it at 32 weeks? Well, a bunch of reasons for that, but really, once the baby gets much bigger, it's harder to appreciate some of this anatomy. It's generally pretty easily seen right there, at that 20-week spot. So, good deal. Jen Mulaney says, "Can you guide us with immune protocol? What is it about?" Yes, indeed. So, we know that the immune system has something to do with people not being able to get pregnant. How does that happen? Well, sometimes it may be there's an allergic situation. Maybe you have a histamine response. Maybe you have a situation where some component of your body is trying to form little blood clots, or maybe some portion of your body is trying to mount an immune response as though your pregnancy is an invader. The immune system is very complicated, and so there are layers and layers and layers of possibilities where the immune system can step in the way. At CNY, we believe that everyone is entitled, from the very beginning, everyone is entitled to a pregnancy. And so from the cost structure at CNY to the way CNY finances things, everyone is entitled to having a baby. It should not just be for the wealthy. It should not just be for the lucky. So everybody can do it. Well, so part of that is that some people are going to have a problem with their immune system, but testing every layer of that immune system really goes well beyond what we're able to do and what's, even cost effective to do in the general population. So we do some pretty straightforward basic things for the immune system. We usually use some low-dose naltrexone. And so what does that do? It increases your endorphin levels, which is good for the immune system, boosts the immune system. We usually use some antihistamines, which has an effect at the level of implantation. We do some blood thinner. We may do some prednisone, which is a little steroid, some baby aspirin. We may do some, we talked about HCG boosters and HCG wash. We do a little bit of antibiotic. We can do, kind of several things. There are really kind of three main levels of immune protocol that we use for folks who are doing IVF, and that's level 2, 3, or 4. I generally say there is a level 1 immune protocol. I would usually reserve that for folks who are doing things like IUIs, inseminations. We want to step it up a notch when we're doing IVF. So that's kind of what the whole immune protocol thing is about. Chef Blackney asks, what about a day 3 versus a day 5 embryo for women who are 38 years old? It's a quandary. And there's not really one right answer, but here's the way we approach that problem. Because if you're going to do IVF, you're going to be faced with the same question. Do I do a day 3 embryo? Do I do a day 5 embryo? And what the hell is the difference? Okay, well, here's the way it goes. When we make an embryo, those embryos grow in the laboratory. CNY has a usual protocol that says, well, if you've got 5 or more embryos, we recommend that you grow those embryos to the blastocyst stage, which is typically going to be day 5. Sometimes it's day 6, and sometimes even day 7. Um, if you have 4 or fewer embryos, we typically say, why don't you go ahead and freeze them or do your transfer, do whatever you're going to do with them on day 3 instead of growing to blast. Why is that? Well, there are many practices that do not do anything. There is no such thing as a day 3 embryo. They're all blasts. Why? Well, if your embryo grows to the blastocyst stage, then it has become a little functioning factory. It is more likely to get you a pregnancy. Because it has survived to that blastocyst stage, it is more likely to result in a pregnancy. So depending kind of on what your age is, so let's say that you're under 35 or under, if we have an untested, that is to say we haven't done PGT testing, an untested blast, that blastocyst or day 5 embryo has a 40% probability of getting you pregnant. Well, that all sounds good. So then why would we want to do a day 3 embryo anyway? And the answer there is, well, the day 3 embryo, it may do better growing inside of you. You're its mom, and your uterus there may be a better place than anything we have in the laboratory. So there's some school of thought that says it is better to have an embryo going inside of you where it may have a chance to grow instead of an embryo potentially dying in the lab. Because if you've got a bunch of embryos and you're growing them out to blast, they're not all going to make it to blast. Some of them will die off. But if we're more limited in the number, we say, well, let's do a day 3 embryo, because then we know we'll have an embryo that may survive in you that might not have survived in the laboratory. So the difference is, so let's say conversely that you got yourself, 15 embryos. Oh my gosh, you made 15 embryos. Well, really, that is just fantastic, right? Yeah, that's a good number, 15 embryos. But since all of those embryos might not otherwise grow, we don't know which ones from looking will. And so transferring those embryos at day 3 means that you are going to have a lot more unsuccessful embryo transfers than you will if you let them grow to blast. So that's really the kind of rationale behind that. You will have fewer unsuccessful transfers if you grow your embryo to the blastocyst stage, Chef. So that's a plus. But if you're more limited in the number of embryos, better to do a day 3 and let that embryo go inside of you. Now, if that embryo is normal and it's going to grow, it doesn't matter if it's a day 3, if it's a day 5, or even if it's a tested embryo, because that normal embryo is much more likely to grow inside of you, irrespective of when you froze it or when you decide to transfer it. Really, the goal is to decrease the number of unsuccessful transfers by growing embryos to blast. So I hope that helps. Let's say hi to all our friends over here on Facebook, because we haven't forgotten you. Let's see, who is number 1? Elisa Marie, thank you for being here today. We've got Courtney and Veronica and Caroline and Jeanette and Candace. Who else we've got? We've got Janet. Good afternoon to you. Let's see, Lauren, and looks like Shong. Okay, so let's see what we have here. Elisa asks, if you have a low AMH, and is it beneficial to do back-to-back egg retrievals? What diet have you seen help with egg quality? So back-to-back egg retrievals are when you do a stem cycle, you do a retrieval, and then about 10 to 14 days later, you get your period. And once you get your period, you can start on your next stem. That's a stacked cycle or a back-to-back cycle. And yes, those back-to-back cycles typically result in better outcomes each time. Now, it may not result in more eggs or more embryos, but it might. Usually, however, what it does give you is better egg quality at least. So, whenever possible, and that's whether you have a normal AMH or a diminished ovarian reserve, but especially in the case of the diminished ovarian reserve, we want and recommend that you do those stacked cycles or back-to-back cycles to the extent that you are able. As far as diet goes, if you're familiar with Dr. Kiltz's work, he is very well known in the keto and carnivore community and can really speak to you ad nauseum about why carnivore is the way to go. What we do know for sure is that carbs are pro-inflammatory. So at the very minimum, even if you're not able to do carnivore to the extent that you're able to decrease your carbs, carbs are pro-inflammatory. The less carbs we get, probably the better off we are. So most diets across the board, whichever one you personally believe in, whether that's Mediterranean or you name it, low carb is probably a function of that. But Dr. Kiltz believes very strongly that keto, which is high fat, moderate protein, and low carb, but specifically carnivore, is the choice you should be making. Courtney asks about I'm in consultations in January. I'm excited to work on growing our family, and we are excited to help you with that, my friend. What are your thoughts, Veronica asks, on Zymot, even if there is no male factor, but the woman has a diminished ovarian reserve? Well, Zymot is a method, or Zymote, I think is technically the correct pronunciation. And they do have a nice website, so I encourage you to take a look at it. Zymote is an add-on that we have here. It only costs $200. There are other practices, I think, that charge thousands for it. CNY pretty much charges the price that they charge us. And what it is a sperm preparation method. And it's this little cartridge, it's about the size kind of a cell phone. And they put the sperm in one side, and inside this thing is a little sperm obstacle course. And so sperm have to run that obstacle course. And so the best and the strongest swimmers come out the other side. Now, in the IVF process, what happens is that an embryologist sits down at a microscope and selects one sperm for each egg. And that's the process called ICSI, intracytoplasmic sperm injection. And they're going to take that one sperm and they're going to place it inside. Now, an embryologist is very, very skilled at looking at that sperm and selecting the sperm that they think looks best. And so they're going to do that whether or not you use Zymote. However, what it does do is that it allows stronger sperm to be coming out of the obstacle course. So even though they're going to sit there and they're going to make the same kind of selection, in theory, they are selecting from a better group of sperm. Now, what is a better group of sperm? Theoretically, that may mean sperm with less DNA fragmentation. What is fragmentation? Well, what is a sperm? A sperm is a little packet of DNA with a motor on it, right? And so if that DNA has started to become fragmented or started to break down, that may affect the way that sperm is able to fertilize the egg, certainly in terms of chromosomes. So if you're able to select better sperm, then that may result in better embryos. The data is somewhat conflicting on Zymote. Most of the studies that have been done on Zymote have been done by that company itself, but it's a relatively low cost addition to IVF. So I think, is it a bad idea? No, I don't think it's a bad idea, but certainly in the population of folks who have unexplained infertility or certainly known different types of male factor infertility. If the sperm count is too low, you need a sperm count of at least 2 million, according to the manufacturer's instruction, in order to be able to use Zymote. But I think its best place is in folks who have otherwise unexplained infertility. I don't think it has too much to do, Veronica, with diminished ovarian reserve, but in other circumstances, I would say, for what if it cost you $2,000 to do it, I might say, the data is not really all that clear that that's a worthwhile expenditure. But certainly from the perspective, a couple $100, yeah, I think it may make a difference. So I generally do recommend it when possible. Carolina asks, excited to have my consultation on Monday. I have a low AMH and was told to consider using donor egg. What are the steps for that? Now, the one thing I will tell you is that there are many practices in the United States that will say, oh, well, if your AMH is, let's say, less than 1, you should consider donor egg, because they are very hung up on the numbers. They're very hung up on being able to show success rates from their IVF. So they really only want to do IVF on somebody who they feel very, very, very confident is going to get pregnant with the first transfer. And so, if you're 25 and you had your tubes tied, and now you have a new partner and you want to have a baby, you're the ideal candidate for those kinds of practices, because you're 25, so you're going to have a real high probability of pregnancy. So sometimes people say, yeah, you should consider donor egg, when really there is absolutely a reasonable possibility that you will have be able to get pregnant with your own egg. So it really depends on what that number is, on where that AMH falls. Now, the AMH, even being low, also does not say anything about your ability to get pregnant on your own, because maybe you can. It really is just kind of saying, well, how is your ovary going to respond to the medication? And that's ultimately really where the question lies. But to answer your question, what is the process of donor egg? Well, we have a donor team, and so you have a consultation where you talk with one of our providers. If it seems like a donor is something that may be of interest to you. And by the way, we also have a process that's called a donor egg add-on, or donor egg backup. And that's where, well, maybe you do try to do a cycle of your own using your own egg, but at the same time, you have selected a group of donor eggs that you can fertilize at the same time, and that results in one way or the other, you're going to leave that IVF cycle with some embryos that have a good probability of being able to get you pregnant. So, but once we talk to you and determine that the donor route is appropriate for you, we put you in touch with our donor team. They kind of talk to you about what the different packages are and what's available. There are fresh donor eggs and there are frozen donor eggs. If you're going to do, and what's the difference? Well, they both have the potential to get you pregnant. But imagine that egg donors, who are usually young, healthy, reproductive women, reproductive age women who have, usually in their younger 20s, most of whom have kids, so they are proven to have eggs that produce offspring. They donate their eggs. Those eggs can then be used either fresh, like they've done a retrieval, and those eggs are then directly fertilized with your sperm, or the eggs can be frozen and thawed later on. Well, freezing and thawing eggs is not a perfect process, like a very straightforward process of doing so with embryos. So if we fertilize an egg and create an embryo, 97% of those embryos will survive an embryo thaw. Whereas with an egg, it may be closer to 75% of the eggs will survive a thaw. Why is that? An egg is just a single cell. So when you freeze it and thaw it, it may be more subject to the extremes of temperature or little microscopic ice crystals. And so let's say that you purchase a group of 6 eggs, you may not get all 6 eggs, because some of them may not survive the thaw. Now, then when you go to fertilize them, well, they are believed to function the same as long as they've survived the thaw. Whereas if you're getting a fresh group of eggs, one that is just coming from the donor, they haven't been frozen. So if you're purchasing 6 eggs, then you will get all 6 eggs. So that's kind of the difference there. And when push comes to shove, there is generally a wait list for getting a fresh donor egg because there are limited individuals who are going through that process, and there are a lot of people who are trying to get those fresh eggs. Whereas there are probably thousands and thousands of frozen donor eggs that are waiting for someone to come and decide to take them. You can select a donor by any criteria that's important to you. So, for instance, maybe by the way this person looks, maybe you want to get someone who resembles you. We know about their their medical histories. We know about their genetic carrier states, and we know about their education level. So there, all kinds of different criteria from which you can ultimately select. And that's kind of how that process works. But plenty of opportunities there, Caroline. But I would also say, let's take a look at what your AMH is. And we may find that, you're not actually such a bad candidate yourself after all. Jeanette says, Dr. Fink, I'm 16 weeks pregnant, but I have a low amniotic fluid. How long does it take to increase? By drinking fluids, and is there anything else I can take to increase the amniotic fluid? Well, now, so the amniotic fluid is that fluid that surrounds your baby. The most common reason, so let's think about how that fluid gets there. Does it just show up? Does your placenta make that fluid? No, in fact, that fluid is your baby's urine. So baby pee is really what's making that fluid. So blood is flowing through you, through your placenta. The blood flows through the umbilical cord into the baby, hydrates the baby. Blood flows back, through the other direction, goes back up and goes to your heart and gets reoxygenated. So that's the general kind of flow of things. If there's a diminished blood flow that's going to the baby, then the baby may become dehydrated and that fluid level can become low. So hydration is probably the number one thing that we look at when we find lower amniotic fluid, especially when you're around 16 weeks. Because when you're that early, later on, we actually can measure the amount of amniotic fluid in there. So it's kind of more a qualitative thing. That looks a little bit low. Hydrate yourself. Usually, if you can stay off your feet for a couple of days and really push fluids and electrolytes, that fluid volume most of the time restores. But what do we worry about with that? Why does that matter? Well, because imagine what would happen if there's a problem with the blood flow that's going to the placenta or through the umbilical cord. Well, if there's a blood flow issue, then that's going to affect both the fluid around the baby and ultimately may affect the baby's growth, because all those factors all that blood, oxygenated blood, is what is needed to make your baby grow along with all the nutrients. So something generally we watch pretty closely. But I'd say a couple of days, a few days off your feet and really push the hydration. And at 16 weeks, my guess is you'll probably be A-okay, my friend. H. Shu says, if someone with PCOS, with egg quality issues and are on all the appropriate supplements in my book, what would be your stim or priming protocol to help with egg quality? Okay, so when we talk about egg quality, by the way, if you're just joining us before I jump into that, we pause now for station identification. It's 34 minutes after the hour. And this is Fertility with Fink and Friends. I am Fink, and you are friends, and this is the place to be every Tuesday evening in this hour where we can talk about all those things that are important. A special hello also going out to my beautiful mom and dad in Southern Alabama. Thank you very much for being here. As always, folks, if you haven't talked to your mom or dad lately, pick up the phone just to say hi. You don't even have to have a story to tell. Just say hi, because it's a doggone good thing. Okay, we were talking about egg quality. Egg quality means stabilizing the DNA that's in the eggs. So we know the sperm that comes out today was manufactured in the male body about 3 months ago. What's not fair is that the eggs inside the female ovary have been there since you were actually in utero. So they've been there for your entire life, and in fact, even since before you were born. So over time, the DNA or the genetic material in those eggs becomes less stable. And that's why it's one of the reasons why it's harder to get pregnant as we mature. And it is also harder to, there's an increased probability of chromosomal abnormalities, an increased risk of miscarriage as we get older. There are some people who are younger who also have egg quality issues for one reason or another. What can we do to improve egg quality? Well, so you also mentioned polycystic ovarian syndrome. And what that says to me is that polycystic ovarian syndrome, folks with PCOS, have a tendency to hyper respond to the medications that we use for stimulation, which means the ovaries pay really good attention to the meds, and you typically make a lot of eggs. So the first thing I would do for egg quality is dial down your stimulation medication so that we give you a little less medication. When you make more eggs, your body's really focused on quantity over quality. So by dropping the dose of stimulation, we're going to make fewer eggs, but we may also make better eggs. Secondly, I do recommend for egg quality growth hormone. Growth hormone is called Omnitrope. It's a little daily injection that you can do for a period of time leading up to your retrieval and also even during that stim cycle. Some people use it for embryo transfer. I think it's much more important as it pertains to egg quality for retrieval. And I like to do a little bit of priming. Priming is where you get a little medication before you start your stimulation. How does that priming work? Well, the way I like to do it is I give you some estrogen and a little bit of progesterone for 10 days or so, kind of starting on cycle day 21 in the cycle before you're going to do your stim. That kind of priming does a bunch of things. One, it may juice up the ovaries. It may help, estrogen and progesterone, as I like to say, are the language that the ovaries speak. And so what it does is that it increases some blood flow that's going to the ovaries, so it helps a lot of those nutrients to be able to get there. You mentioned the supplements. I think the supplements are very important. Well, I'm sorry, I'm getting sidetracked there. But what else does the estrogen and progesterone do? It helps to sensitize your pituitary gland in the brain so that you may respond better, but also it helps to synchronize the growth of the follicles in the ovaries so that you're more likely to get a bunch of follicles that are about the same size, as opposed to having follicles that are all over the map, that you've got some that are 19 while you've got some that are 15 and you've got a bunch more that are 10, that they're just all over the map. It helps to synchronize the growth of those follicles. So I think, and that, really also does improve egg quality. So these are the kinds of things I think of for egg quality. And you mentioned the supplements. I do want to mention that there are some evidence-based protocols on what can a handful of vitamins do to help our fertility. I've got that in a book that's called The Vitamin Victory. You can find that book on the LinkedIn, on my Instagram page. It's called Linktree, not LinkedIn, Linktree, LANKTR.ee. That's a Linktree / Randy Fink MD, or go to my Instagram page, which is Randy Fink MD. And the link in the bio has that book there called The Vitamin Victory. It's a $7 ebook. It's got the whole list and the descriptions of what it all does, and also has a discount code. It'll save you about $20 on getting those supplements as well. You might also take a look at the Molecular Fertility brand, which is Dr. Kiltz or CNY's brand, molecularfertility.com. Also some wonderful supplements there. So hopefully that helps you. Let's see what else we got going on. Monica Ashley said, I did 2 transfers that were unsuccessful. I was diagnosed with endometriosis, and the meds were denied through my insurance. That is astonishing to me. But sometimes, I mean, you have to remember that insurance is not here to protect you. Insurance is, is designed to make money for themselves. So sometimes there are some ways around that, especially if you can document that you have a history of painful periods. So if you have painful periods, and usually you have tried two different medications at some point in your life. It doesn't have to be recently, but at some point in your life, those two different medications are typically one, birth control, unless there's a reason that you can't or shouldn't take birth control, or two, a non-steroidal anti-inflammatory, which is ibuprofen. You document that you've taken those two medications, that you've considered surgery, but you don't want it, and that your periods are bad. That's usually enough to get the insurance to approve those medications, especially because this is not long-term medications. You're looking at 60 days worth of medication, and there are oftentimes that you can get that very affordably as well, self-pay if you need to. Surgery is an option, but which will be covered by your insurance, but it's often much more expensive, and surgery has its risks as well. But when we find endometriosis from the non-invasive test, which is called Receptiva, then the recommendation is that you use 60 days of suppression of medication, and that's what we're talking about here, before doing an embryo transfer, and that will dramatically improve your transfer outcomes. What sperm treatment do you recommend for elevated white blood cells and pH? The 2 weeks of antibiotic worked, and then returned 6 months later. He's on 3 weeks now. It oftentimes does return, and that may be due to something called chronic prostatitis. The prostate gland sits beneath the bladder and contributes a large portion of the fluid that is associated with ejaculation. It's called, really the semen. Semen is made up of fluid that comes from the prostate. It comes from the seminal vesicles, and it includes the sperm itself. Most of the time, some of it's coming from the seminal vesicles, but most of that fluid is coming from the prostate. And so the doctor can check the prostate and see if there's chronic prostatitis. But really, the antibiotic treatment is the treatment of choice. But sometimes prostatitis can be chronic. That is to say, it just keeps coming back. Now, some guys with chronic prostatitis don't have any issue with that at all. They don't feel it. It doesn't bother them. It ain't no big deal. Some people are very uncomfortable with it. It can cause chronic pelvic pain in men, and oftentimes some voiding symptoms, some ejaculatory symptoms, and even erectile dysfunction. So it's a pretty straightforward thing to diagnose and to treat, but sometimes you have to treat it repetitively. Hello to Zenaida in Miami. And Bama Gal, nice to see you. Sharmilla, hello. Noodles for Life, howdy. A special hi to Allie Craig here as well. Sharmilla asks, I am on the HCG boosters. My estradiol is 1980 in the Midway Labs, and my progesterone is 36. Is this normal? So the estradiol really doesn't matter. The only thing that matters about estrogen is, did it make your lining thick enough? So the number there, we don't care too much about, but yep, that's a pretty good number. And the progesterone level at 36. So if you're doing a medicated cycle, that means you're on progesterone and oil. Then we want that progesterone level to be at least a 20. At 36 is very good. There is no number there that's too high, by the way. And if you're doing a natural cycle or a modified natural cycle, we're looking for that number to be above a 10. So, yep, Sharmilla, you're in a good place there, it looks like. Hi to Emily Watson. When to decide to cancel a cycle after a poor response to stims? Started on 150 of follistim and up to 200 on day 6. Day 9, still 20 follicles, but all small and no growth. Well, if you're at day 9, so, the average stim is between 9 and 12 days. And so if you get much beyond that, then we do start to have a suffering of egg quality. And so, Emily, what happened there, if you've got, 20 plus follicles, the thinking was, well, gosh, I bet your AMH is a little higher. And so we want to dial back the number, dial back the stimulation so that we don't hyperstimulate you and make your ovaries the size of watermelons and make you get 80 eggs that we don't need and will just make you sick. So they went with the lower choice. They went with 150 and then saw that you didn't respond. So what does that mean? That means that you're a little bit resistant to the medication. So I would say that certainly by day 9 or 10, if you're not, really close to having mature follicles, I would say it's probably better to stop. It's probably better to reset and reboot and revisit what kind of dose you need in order to get you to respond. Because it may be that you started off on too low a dose. It's not enough stimulation there. And because of that resistance, you didn't get to where you wanted to be. Doesn't mean that you won't, because I'm sure that you will. It's just going to take a little bit of nuances in order to be able to get you there. Rosa says, I'm about to start Oralissa for 2 months prior to my embryo transfer in January. What's the best time to do a saline sonogram? Will it leave fluid in the womb and no period? Is there no period while taking Oralissa? So for many people, most of the time, if you start Oralissa for endometriosis suppression, around, at the time of your period, then most women will not get a period while on Oralissa. If you start in the middle of the cycle, you may have some irregular bleeding, and you may still get a period under that circumstance. So anytime, Rosa, while you're on the Oralissa is a fine time to do the saline sonogram. And no, it does not leave fluid on the inside. So especially since you're going to be taking the time out by doing this 60 days of Oralissa, use that time wisely, get some testing done like that saline sonogram so that you really can make sure that your cavity is picture perfect. Can HCG help improve sperm? Well, so HCG is functions in the body like LH or luteinizing hormone. Sometimes we will use subcutaneous injection of HCG into a male who has a low sperm count, because LH or luteinizing hormone stimulates the cells in the testicles that make sperm. A lot of times guys who have been on testosterone will have or almost always guys who are on testosterone will have a low sperm count. And that's because the testosterone, when we're getting it from the outside, our bodies we're fundamentally lazy creatures all the way down to the cellular level. So our own bodies will say, well, we're getting it from the outside, so geez, we don't have to make it anymore. Those same cells are very near those same cells that make testosterone, are the cells that make sperm. So if you're getting testosterone from the outside, your own testosterone production shuts down, as does your sperm production. Now, we can give you some medication, and one of those things is like HCG to try to help increase the production of sperm. Sometimes it works, sometimes it doesn't. It depends really how long he's been on testosterone as to what kind of effect you're going to get there. Jessica Karen says, I am Jessica. Hello, Jessica. It's nice to meet you. I'm Brazilian. Gustoso, living in Texas, and I started today my first retrieval with you guys. I wish to see the snow this month and see a lot of good eggs as well. Well, that sounds like a great plan. Even though I think Thursday it's supposed to be 60 degrees here in Colorado Springs, there's still plenty of snow up on the top of the mountains. We look at Pikes Peak up there, which is a beautiful mountain peak. That is the Purple Mountain Majesty, if you weren't aware, and it's now a snow-capped peak, and all the Front Range here is kind of covered with snow up at the top of the mountains there. So it's really very, very beautiful, Jessica. We will look forward to you coming to see us in Colorado. Is there a CNY in Texas? There is not at this time. Create Davis, will you be in the office next week to do my transfer? If you are doing it in Colorado Springs, then yes, I will. You just have to ask. My wonderful partner here, Brandis, does a lot of our transfers. If you have a preference, you can just ask for either one of us. Bryn says, I think we talked about that one before. Let's hop back over to our friends on Facebook. We talked to Candace a little bit about egg quality. Any chance of a full center in Atlanta? I don't know if that's part of the plan yet or not. Atlanta is a monitoring center at this time. Will it ultimately become full service IVF? Don't know, but Sarasota is really not that far, so you don't have to travel too much if you're in the Atlanta area. Plus, to be honest with you, doing your monitoring in a CNY facility, I think, is always a better thing if you can, because then we have immediate access to your results and you're taken care of by a smaller group of people. Our global travel team is really wonderful in terms of being able to manage all these cycles remotely. And the system is set up so that you can stay at home and monitor at home as much as you can. But there are a lot of folks on the global team because there are a lot of folks who do their monitoring remotely. There are fewer folks in each of our individual centers, which would be Sarasota, Colorado, Syracuse, Buffalo, and Albany. So if you can monitor in one of our centers, there's just less people involved with your care. So it's just a little bit more directed, I think. Let's see. Janet says, what does this say now? Senate Bill 729 will kick off in July 2025. I don't know what that is. I had my almost 2-year-old baby boy all out of pocket. Will this new law in California be accepted in Colorado? I don't know what Senate Bill 729 is, but I'm guessing what you're talking about there is what they call a mandate. The mandate is when a state says that that IVF or fertility services must be covered by insurance. We have such a mandate in Colorado, and there was an expectation that when it was going to take place, that there was going to be floods of folks coming into fertility centers looking for treatment, and it didn't end up happening that way. Why not? Because there are a lot of loopholes in those laws that allow employers all kinds of options to be able to carve out fertility care. So the employer has to have a certain number of employees. That's usually the biggest one. So smaller employers don't have to abide by the law. So really, it has to do with insurance, not so much CNY Colorado. If what that bill is what I'm thinking it is, I think it has to do with, well, what's your insurance going to try to do? Oh, and the other thing is often, well, where's the employer based out of? So if you have a New Mexico-based employer, but you live in California, they may not have to cover it, even though California will now have a mandate. So I'm not familiar with the California law, but that is my gestalt on that. Vanessa asks, is it safe to do an embryo transfer a week after getting a saline sonogram? And I would say no. You don't want to do a saline sonogram or anything that's going to be touching the lining of the uterus in the same cycle that you're going to be doing an embryo transfer. We would not do that, and nor would I recommend that you do that. So at CNY, we often say, hey, we'll do almost anything that you want for us to, but I think that would be a very big mistake. Shong asks, if a patient has endometrium cysts in their lining, are they able to do a transfer? Well, oftentimes, we want to make sure that your uterine cavity is evaluated, and oftentimes what looks like cysts in the lining are actually little endometrial polyps. And a polyp is a finger-like growth that sticks up like a tree trunk, hangs down like an icicle. And when you have that, we want to be able to put a camera inside to remove those, because that can be a problem, a mechanical issue with the lining of your uterus. So if that's what your ultrasound showed, cysts in the lining, that means you really do need a hysteroscopy to take a look there because my suspicion is that you have polyps. If we know that you have polyps or even are suspicious that you have polyps, I wouldn't want you to do an embryo transfer because you invested an awful lot to make those embryos. Right. So we want to make sure that that lining is just perfect, that it's the perfect little baby house for your embryo. Hi to Jamie. Thank you for being here. Lauren asks, I'm 40. I have an AMH of 3.34. Very good. My last two retrievals, I've gotten 11 to 12 mature eggs, 10 to 11 fertilized, but only got 3 embryos each time. Poor and fair quality blast. Any suggestions? Well, so my guess is with that little higher AMH, you may be have ovaries that function like polycystic ovaries, meaning to say you have a tendency to hyper respond. So dialing down the dose may be one thing, and it goes back to the other stuff we talked about a few minutes ago. My usual recipe would be 10 days of priming in the cycle before. I'd recommend you be on the supplements on the list and that you be on Omnitrope as well. Now, the other thing, Lauren, I might consider for you is using some metformin. Metformin is a drug that's used for folks with diabetes, but we use it in women with polycystic ovaries. And I find that really for anybody with an AMH that's greater than 3, metformin has a tendency to improve our egg quality by decreasing our insulin resistance, which ultimately really kind of decreases the hyperestrogenic environment that's happening around the level of the egg. So best of luck there, Lauren. Hey to Tracy, you did my egg retrieval this morning. Oh, hello. Seems like I've had a period in the days leading up to it, which really stressed me out because I thought I'd ovulated. Why did that happen? I didn't feel prepared for that. If it's expected, I did a stem for a longer time, and my last day of estrogen and progesterone pills was on October the 30th. So the first thing I would think of, Tracy, is that it may be, it's probably a hormonal type of bleed. And so it may have been that you had a little fluctuation of hormone levels and that made you bleed. Or if you had stopped your estrogen and progesterone October 30th, well, here we are 10 or 11 days later, you may have grown some lining there and then started to slough it off. Sometimes what happens is that when you're on that estrogen and progesterone and then you stop it, you get a withdrawal bleed, which may be like a period. And what's happening is that unless your estrogen level is rising fast enough to stabilize that lining, you may just slough it off. So it is not entirely an abnormal thing. It doesn't mean anything is wrong with you. Now, certainly, and it really doesn't relate at all to what's happening in your ovaries, because your ovaries are doing what they're supposed to be doing. Now, that scenario wouldn't work if we're trying to do a fresh transfer, but my guess is that was not in the cards. We would do it a little bit differently, I think, if you were trying to do a fresh transfer. And lastly here, it's actually not last. We got a bunch more here. Actually, let's get back over here because we're going to be out of time shortly. Hello to Lindsay Lane, Maru Calvash, Maria Calvash. You are the best. Thank you. I appreciate you saying that. My friend from Miami. Let's see. My FSH has looked good. My AMH is 4.4. So we've been surprised things haven't taken off as expected. This is our first cycle of IVF for endometriosis. I think the most important lesson to learn here is that, you kind of want to have an open mind because, the body doesn't always read the textbooks and it doesn't always respond the way we expect for it to. And every time something happens, every time we do something, we learn something about you, which means that we can tinker and change some things a little bit. We can treat you with a little more nuance based on what we've learned. So a lot of times people say, I had a failed cycle, and I don't like to think of it as a failed cycle. I like to think of it as, it was a cycle that was unsuccessful. It didn't get us a pregnancy, but what did it do? we learn something from it for sure. This reminds me of something that I'm working on. I'm doing a little writing now, and I had a chance to write this out, and I really do want to share it with everybody because as we start to wrap up here, I think that this is really important. Celebrate your individuality and the unique qualities that you bring to this world. You are a mosaic of strengths, of talents, of quirks, and it's time to let them shine. Create um, a world for yourself that is able to lift your spirit and spark joy, not only in yourself, but in other people. Design your style, one that reflects your identity and your creativity, whether it's bold colors, if that's who you are, or a subtle elegance. Let your outer expression match the vibrant soul that you have within. This celebration of self is not an indulgence. It is a declaration of who you are, a reminder that you are one of a kind. There is no other person on this earth like you. And that leads me to that sign behind me there. Every step forward with kindness. The world is not a kind enough place. Anything that you can do, any little random act of kindness for a stranger, maybe it's stopping and petting a dog. Maybe that'll make you happy. It's just smiling at a stranger or waving hello, doing something to help someone when they are least expecting it. You never know what's going on in their day, and anything that you can do to add to kindness in this world is truly making this world a better place. Just by being here, you are making this world a better place. Every step forward with love, and most importantly, with hope. Because tomorrow, my friends, is a new day. And what happened yesterday is a memory. What happened today is going to be an afterthought. Tomorrow is a new day. Live it with the hope of knowing that great things can happen to you. This fertility business is not the book of your life. It is merely a chapter. And what are we doing? We are here to rewrite it together. So until next week, thank you so much for being here. It is such a privilege and an honor to be able to have a little bit of your time this week. I will look forward to seeing you next week. And until then, I'm Dr. Randy Fink in Colorado Springs. I am Fink. You are friends. God bless. I wish you all the best. Good night.